Today, we're going to talk about birth and the newborn infant. Generally speaking, the media portrays newborns as these cute little things that are just angelic and quiet and sleepy and perfect and rosy cheeked and blah, 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 blah. In reality, it's not quite that pretty. We're going to get there, but we're going to first talk about the process of birth. We're going to talk about techniques to give birth, but yeah, not going to be quite as romantic a picture as you might often be given. So first of all, do you know any birthing techniques? Just think for a second. There are a ton of them out there. Some might be better than others, but I'm pretty sure you might not have heard of this. This I saw a couple years back. Dolphin-assisted birth. One of the people asked to comment on this said something along the lines of, "This might be the worst idea in the history of the world." So this is not very common, but let's talk about some more common ones. So the first one is Lamaze. This is a pretty popular one, and Lamaze is based on breathing and relaxation techniques. There are training sessions where people will learn exercises in how to relax different parts of the body. And there's a coach, which has historically typically been the father, but it can be anybody, trains with the mother. So typically both mother and father, or mother and whoever, are there. And the idea of Lamaze is that instead of tensing up, that you should relax during birth. Which easy for me to say, I know. And the idea is that this tensing that people often do can actually make the pain worse, and that it can kind of turn birth into the Chinese finger trap. You know, the device that you put your finger, it's a long tube, you put your finger into both ends, and if you try to pull out really hard, they'll get caught, but if you slowly pull your finger out, they will be released. So you try to focus on something calm, and the goal is to learn how to deal with pain in a positive way. Remember, this is going to be more pain than most people have ever felt before, and so it's difficult to deal with. So is it a good thing? Well, yes. Mothers who use Lamaze report that they have a sense of mastery over the process. However, the problem is that we don't have a real experimental design here. People choose to do these things. So it could be that the people who choose to do this more active type of birthing might be more likely to enjoy it in the first place. So we could have unequal comparison groups. And another issue with this is that it's typically not done in low-income groups. There's transportation costs, financial flexibility, time is a big one. You can't I can almost say with sure that if you are working two jobs, you're not going to be able to do this. So it's good for those who do it. Might be a selection effect, but there are some issues not surrounding the program as much as just how practical concerns around it. The Bradley method is sometimes called husband-coached therapy, and this is based on the idea that birth should be as natural as possible, with no medication or medical intervention. And you tune into your bodies because, in theory, from an evolutionary perspective, your body knows what to do. Just let it do its thing. Now, they are also taught muscle relaxation techniques similar to Lamaze, but it's maybe a little bit more holistic depending on where you're going, where good nutrition and exercise are also important parts of this. The most controversial part of the Bradley method is that parents are at times urged that physicians are unnecessary and sometimes even dangerous. I'm skeptical of that, possibly because in my mind I'm a pessimist, and I would rather have medical personnel standing by just in case something were to go wrong. And in hospitals, a lot of people want to go natural with their births, and when in reality, there's very few natural births left. For the most part, if you go to a hospital to give birth and you are not, crowning when you're walking in, um, you are going to get an IV right away, just set up so that if they need something, they can put it in there. There's all these artificial lights, these people you probably don't know around. It's not it. There's no such thing as natural birth anymore. So I can understand the idea that at least not no such thing in hospitals. So I can at least understand the idea that you might not want that, but sometimes there can be life or death decisions that need to be made. So it's a personal decision, of course, and it would only be, I mean, the vast majority of people could have births at home and be just fine. But it depends. I mean, for the most part, if there is any kind of um, potential for problem popping up, then some people think that um, you should stick with them. Hypnobirthing, newer, and the only reason to bring it up here, it's not really a thing that many people do, but your book talks about it. This is where there's self-hypnosis to gain peace and calm and try to reduce pain that way. And we do know that this works, can be effective, but let's get to the big question here. Which one's the best? Well, there's actually not really a best. It doesn't seem like there's one that you should do. What seems to be the best option is the one that you believe in. If you don't believe in it, it's not going to work. The hypnobirthing, I don't know about that. I am not someone who can be hypnotized, and these kinds of things sometimes just weird me out. So I probably would not be the right person to jump in there. So if we had an experimental design where we randomly assigned people into these three groups, we could see who did the best, quote unquote. But that's not really how the real world works. You don't randomly get assigned into something, you get to pick. So the better way to do it would be just to let people pick and see how it works. So there's not really a right one. It's more that if you are forcing yourself into something, that is probably not the best. So who helps you deliver during this? Well, that is a wonderful question. I was, where was I? Earth Fair in Birmingham a couple years ago, and I saw a bumper sticker that said Alabama wives or Alabama mothers deserve midwives. And there actually is somewhat of a controversy over this, and you can actually look this up. This article, I just copied a link from there. But in the last few decades, more and more people have been moving to a midwife. And midwives are nurses who specialize in childbirth. They are used primarily when no complications are expected, about 10% of births in the United States. However, elsewhere in the world, it's more than 80% of the time it happens. And so this is another case where if there doesn't seem to be any complications coming up, you might be reasonable to do. But this the midwife controversy in Alabama is something that is a little bit more interesting because some people might think that this is just a southern state trying to control a woman's body or something like that, but it doesn't seem to be that. Other states have laws, including Alabama, that outlaw midwives from being used if you are not within a certain distance from a hospital. And it turns out that medical professional groups are actually behind this. Some people could cynically say because it helps them get more money, but also they do say that just in case something does happen, because just because you haven't had complications for the entire pregnancy doesn't mean that you won't at the end. An umbilical cord could get wrapped around the head or something like that, and you could need emergency medical care at the time of birth. So it is controversial. It's a little bit more complicated than some people might make you believe. The second type outside of just being in a hospital is with doulas. Doula, it's spelled Doula, And doulas are trained to provide emotional, psychological, and educational support for women. Now, depending on where you live and who you talk to, it could even be that no education is required for you to be a doula. And this is, they just simply don't replace OBGYNs or midwives. Now, they can be used reasonably. Reasonable people have used them. They seem to be best at providing alternatives, especially if you like herbal remedies for things. Other things haven't been working too well. You're concerned about medications and this and that. They're good at giving alternatives. Um, they also do seem to help women have less reliance on drugs, and they do speed deliveries up a bit. So it's not all bad, and by no means does using a doula mean that it's a bad thing. It just means that maybe even more than just a random OB, you'd want to check out the training that doulas have got and make sure you trust whoever it is. If it's someone who has helped hundreds of births before, which there are those out there, go for it. They know more than I do. But if it's someone who, it's a little bit more questionable, just maybe have a little bit more reservation about that. So, who delivers? We've talked about that a little bit. Let's talk about pain relievers now. So, are you going to use pain relievers? If you are a woman, think about, would you want to use pain relievers in during pregnancy? And if you're a man, would you care if they did? My personal opinion as a man, I didn't care. I told my wife whatever she needs. I don't know what it's like. For women, it turns out that about a third of women who get pain relievers get epidural anesthesia, and that causes numbness from the waist down. Now, there are newer types of anesthesia, so like a walking epidural, that gives a more continuous dose of anesthesia so women can move around, but it really depends on how they do it at different hospitals. And different hospitals will even have different guidelines for when you can get anesthesia. So sometimes they won't let you get anesthesia before you are a certain amount dilated. Sometimes you can get it straight from the beginning. It really depends. And there can be some problems that can come up here. Drugs can be good for the mother, but anything the mother gets to the fetus as well. There are minimal effects on the mother that can have big effects on the baby. It can actually slow oxygen flow to the fetus and therefore slow labor. Children also can have poorer motor control, can cry more, can have difficulty initiating breastfeeding early on. Now, some say that some say that these are huge deals. In general, there's not any long-term effects, it seems, which is why they're allowed. If there were these big long-term effects, we would outlaw it, right? I mean, like thalidomide, we'd just say, no, you can't get it. But there don't really seem to be long-term effects. It seems to be short-lived, if anything. And the general medical guideline is women's requests should be met, but with an attempt to have the minimal amount of drugs, which makes sense. How long can you stay in the hospital? In the 1970s, the average hospital stay for following birth was almost 4 days. In the 90s, it was 2. And then insurance companies started to want to only pay for 24 hours in a hospital. Now, Congress passed a bill that mandated 48 hours, and doctors generally agree on this. This is one case where people seem to say that government regulation was good. Now, in the 48 hours, most of the time, you might not even need, quote unquote, to stay for 48 hours, as long as they could leave earlier if they get you the discharge paperwork and all of that kind of stuff, which can be annoying and take a while. But it really can just allow for the tests to be run, for your child to get the proper vaccinations, for them to monitor you and your bleeding and any kind of immediate postpartum issues. that are occurring. So 48 hours seems to be what doctors are recommending. It doesn't seem like there's any kind of push for it to be longer. But if there are medical concerns that pop up, if you have to be, have a child sent to a NICU or something, obviously, or if you yourself have medical issues, C-section, you generally can stay for a day longer. Things can occur. If there are reasons to stay for longer than 48 hours, it's probably going to be covered. In terms of health screenings, it's recommended to get 29 tests, at least the last I saw, but the number that you are required to get varies state to state. Some places it's over 30 that you have to get. And every year, it's estimated that 1,000 babies suffer from disorders that could have been detected earlier if appropriate screening was conducted. So this is not to say, of course, at this point in time, once they're born, you can't abort. This is just to say that they get treatment sooner, which everybody wants. There is the question of cost, and if it's in any given state, if the average child or average person is 1 in 10,000 going to have an issue, is it worth it to get it? We can debate that some other time. And also, immunizations have been criticized, but wrongly. There's no evidence that immunizations do anything but good. And in fact, it seems that immunizations have become the victim of their own success. We no longer see the need for immunizations because immunizations do such a good job. Polio completely eradicated because of immunizations. Many other things has been similar. So now people can sit back and say, well, my child shouldn't be immunized because they're not going to have, not going to be exposed to this. Well, but it turns out that, they can be. And even if you are not, the herd immunity argument is fairly strong that if you don't want to give immunizations to your kids for a personal reason that logically doesn't exist, why should a child who cannot have immunizations because of a compromised immune system, why should they be exposed to your child? If there was evidence that immunizations caused anything bad, then okay, but it seems to be a bunch of anecdotal evidence as opposed to any real strong empirical evidence. There have been many, many, many studies done that show that there is no link, especially between vaccines and autism. The person who initially came up with that got disbarred and is no longer a medical doctor because he made up the data. Okay, so let's get to the birth process itself. Labor. Braxton Hicks contractions you will have heard about by the time you give birth. This happens about 4 months after pregnancy or so. It can, at least. And this is where the uterus will occasionally contract. That just prepares it for labor. Sometimes it's falsely called false labor, but it doesn't really mean anything. They're just going to kind of happen. And oftentimes your physician will just say, call the office, and they'll probably tell you you're just fine. And these are not timed like regular contractions. So after about 266 days, or 38 weeks, from conception, a protein called corticotropin-releasing hormone is released, and it triggers the release of other hormones that starts the birth process. So here we go. There are 3 stages of labor, which are conveniently called stage 1, 2, and 3. So stage 1, the first stage, is where contractions go every 8 to 10 minutes and last about 30 seconds. Now they will change over time. They will start about every 2 minutes and last for can be a couple minutes. Contractions allow the cervix to open. As you see in the slide, cervix is right here. Allows it to open and eventually expands to around 10 centimeters that allows the child's head to get out. The newborn, generally speaking, make a fist, and that's about the size of a newborn's head. And so that's a lot of pain, I can imagine, trying to get the cervix to open up enough to allow the child to get out. Now, the length of this first stage depends on age, race, ethnicity, but it can be for more than 24 hours. And sometimes you can actually be going into labor prior to even really feeling it, depending on your situation. Those people are often quite lucky. Um, if you are someone who needs or opts for an induction is where they give you Pitocin, which causes labor to occur. Depending on how much Pitocin they put you on, the contractions can come even faster and even harder. I would be amazed if anybody could get through a induction without using drugs. The second stage of labor lasts around 90 minutes. This is where the head emerges further and further with each contraction. And it's fairly straightforward. That's what's going on during this. Sometimes procedures are used to increase the size of the opening. There can be snips with scissors, an episiotomy. This is oftentimes one of my favorite things to say in class, because so many people don't know about this, that women, it's like, I say this and then their jaws just drop. It's like, yes, this can happen. But as with so many things, they don't do it for fun. They do it because if they didn't, then oftentimes you would tear. And that tear can go in jagged directions, and can be harder to heal. If there is this little snip, they can just sew you up following. And I know this all, easy for me to say, but you probably would prefer the episiotomy to the tearing. The second stage is over when the baby is completely out. The third stage is the quickest. It's just a couple minutes. It's when the umbilical cord and placenta are expelled. The first pregnancy that my wife had, we barely even noticed this was occurring, except it looked like someone was trying to give CPR to my wife's stomach. They were just pushing down on her stomach to help get everything out. It's a weird stage, but sometimes you won't even notice it occurs because you're going to be so ecstatic because there's going to be this new baby and you're going to be looking at them, and hopefully everything will just be so wonderful you won't even know. So we've got ourselves a baby. Congratulations. So after birth, there is the first scale. The first test that really do is called the APGAR, and it stands for appearance, pulse, grimace, activity, and respiration. And the child is given from 0 to 2 points on each of these things, so it's a 10-point scale. There's a table in my version of the book. It's page 85, table 3.1. Most children score above a 7. 10% of those who score under 7 will need help to start breathing. And generally, if it's under 4, there will be some kind of immediate life-saving intervention necessary. It can also indicate birth defects or other problems that are already in the fetus, but not necessarily. We didn't know that my daughter, when she was born, we didn't know that she had Down syndrome, and she got a 9 on her APGAR, which is pretty good. So it's not always that everything is 100% rosy. My daughter also had a huge heart defect, so that doesn't show up in that kind of scale. But it's just a first kind of initial check of the child. Bonding. So this is something that many people think is critical. Bonding is also oftentimes referred to as skin-to-skin time, where following the birth, the physician or nurses will ask if you want to do skin-to-skin time, and they will take the naked child, put it on naked mother's chest, let the child nurse. And some people think and thought that it was one of the most important things in life. So just take a second and think about, why do you think people used to think about this? We've talked about this. Why do people think this is so important? Well, in part, it's because of Lorenz's geese and the notion of this critical period right after birth. turns out that, from a humanistic perspective, it sounds nice that this skin-to-skin contact is critical for a bond. And it is true that children who are not able to do this do worse than those who are. But it's not necessarily because of the bonding. It's actually likely because of the health concerns. Because we are dealing with unequal comparison groups here. Children who are unable to do this bonding time following birth oftentimes have medical conditions that make them have to go straight for the incubator or emergency surgery or something. So if you are able to hold your kid, it means because that you are able to do that because there's no immediate life-threatening thing going on with the kid. So it doesn't seem that there's support for the kind of goose-like connection between a mother and child. And if this is part of why adopted children can do so wonderfully with people, even if they're not there at birth. So it sounds great. It does. There is evidence that that there is, for a few days, maybe some difference in the mother-child relationship. It could be that it could be that the mothers who aren't able to hold the children are more anxious and things surrounding the medical diagnosis and not just the bonding itself. And it doesn't actually lead to anything down the line. So long term, there's not any differences if you take into account medical issues. But there is some evidence that touching a child can help for physiological growth, and for breastfeeding immediately following birth can be a good thing for mothers as well, physically and emotionally. In terms of postpartum depression, it occurs in about 10% of all mothers. And this is this deep feeling of sadness that can be days, weeks, months, years. Your book says that about 1 in 500 have a, quote, total break from reality, end quote. That would be mothers who kill their children, or the like. Now, that is very, very rare and not something anyone should be concerned about, they themselves having it. Usually, postpartum depression is a surprise, but there are some warning signs. People with past clinical depression or a family history of depression are more prone to it. And women who are less prepared for the child are also more prone to developing postpartum depression. Some people have theorized that this depression can occur in part because of the hormone swing at birth. There is a huge plunge in hormones that takes place immediately following birth. There's a lot going on physically, emotionally, and it just seems like for some it can, the neurochemistry can kind of fire the wrong way at times. We don't think it has anything to do with women not being able to handle it or anything. That's, we don't want to blame the mothers in this. Most of the time, it is just a kind of freak accident. Okay, so let's return to our pictures. Babies don't actually look great. The baby on the right-hand side of this, you can see he's got all of this white on him and everything. Cottage cheese, greasy substance. It's called a vernix, Vernix. And this is a substance that actually smooths the passage through the birth canal. It's kind of a lubricant, not a bad thing. It's wiped away easily. Blood, there will be blood. That is wiped away as well, not a problem. There are also puffy eyelids, as you can see on both of these kids. There's just likely just fluid in them from labor and the like, and that'll go away shortly. The child on the left, you see the smushed nose, the cone head. That baby's head is very cone-shaped. The child's skull is not set in place because they're coming out this narrow birth canal, so evolutionarily we've got this head where the bones aren't fused, so you can have a little bit of misshapenness to get out. Having a head that's too big, as we'll see in the next slide, is not a good thing. But the cone shape will go away relatively soon. It's not really a problem for anything. So we've talked about birth as it goes ideally. There are some complications, though. Preterm or premature infants happens about 11% of the time, and preterm is defined as having been born prior to 38 weeks. The average newborn is 7.5 pounds, and low birth weight infants are when they are born less than 5.5 pounds, and this is only about 7% of the child. Most children who die following birth are underweight, although not all. So these are just kind of warning signs. So being low birth weight, being preterm, not necessarily bad things, but they can just be signs that you want to make sure things are going okay. And most low birth weight infants are preterm. Now, some infants are small for gestational age, and those are children who are 90% or less of the average weight of same age peers. So if you're born at 24 weeks, you could be small for gestational age if you're 90% of the average 24-week infant. If you're 90% of the average 30-week infant when you're 30 weeks, that you get the point. This is just because of delayed fetal growth. It could be inadequate nutrition during pregnancy, but most of the time, these things aren't too big of a deal immediately. They might need to stay in a hospital a little bit longer. Preterm, low birth weight infants are more vulnerable to infections, especially in the lungs, so they're more likely to stay and be on incubators. Now, very low birth weight is where we get into the more major issues. This is where a child weighs less than 2.25 pounds or have been in the womb less than 30 weeks. Here, eyes may be fused shut, earlobes might look like flaps of skin, the skin color can be dark red no matter of the race. And before the 1980s, they would have died outside the womb. Now, the age of viability is around 22 or so weeks, depending on where they are. So viability simply means that they can survive outside the womb with medical assistance. If a child is born at 22 to 23 weeks, they have a 71% chance of dying. If they're born 24 to 27 weeks, it's a 23% chance. And 28 to 31 weeks, it's about a 4.5% chance. There's a figure, page 94, figure 3-4, 94 in my book at least. On top of these medical issues, there are big complications for them. Long medical stays, high medical costs. Very low birth weight infants cost on average between 3 to 50 times more than a full term. And there are some ethical concerns. Your book points out, should we put as much of that financial requirement behind an infant who has such a low chance of surviving? Should we take that money and instead spend it on food for the hungry, where we know it can do some good? We don't need to get into that at this point, but think about that a little bit. Sometimes premature and low birth weight issues can come up because of problems with the mother's reproductive system. Those mothers under age 14 are the most likely to have preterm children. Now, on the other side of things, we have post-mature infants. And post-mature infants are every woman's, well, maybe not worst nightmare, but they don't want this. This is where children are 2 weeks past their due date. And historically, this was a big, big problem. Mothers are not supposed to handle children that big. They can get so big they can't get out. So these days, if they let you go 2 weeks past, they would schedule a C-section and just get them out because they don't want the chance that the child or the mother could die in labor. also can be a problem in that the placenta can be too small and they might not get enough blood flow, not enough nutrients, and the blood might not get enough to the brain, which obviously can cause issues. Labor itself, as I said, can be riskier as well. A fetus the size of a 1-month-old has a hard time getting out of the birth canal. Mentioned C-sections already, but let's hit that quickly. C-sections are most often done when the fetus is in distress. If there's a sudden rise in blood pressure, if there's blood coming from the vagina. Older mothers are more likely to have them when they're 40 plus. But also you can have just a quirk of luck, and if children are born in the breech position, or if they're transverse, so the breech position is where they come out feet first. That's 1 in 25 children have that occur. That's unideal. The umbilical cord can be compressed, can deprive air to the baby, which is dangerous. And if they're breech and ready to come out, they will likely do a C-section. They will also, though, try to manually turn the infant around, which I can imagine sounds like about as much fun as I'm thinking. But yeah. Transverse position is when the baby is crosswise, meaning they're coming out butt first. That's definitely a time for a C-section. Now, C-sections have become more and more safe over the years. However, it's still a major surgery, and you're more likely to have an infection. And there's also some things you might not think about, which is that the relatively normal trauma of childbirth can cause the release of hormones that might help transfer children to the real world. Those who are born via C-section are actually more likely to have breathing problems. Because of this, they're not recommended. It's also more expensive. So across the board, it seems health insurers, but also doctors don't want to do a C-section unless it's necessary. Stillbirth occurs in less than 1% of children. This is where they die either before or during the childbirth. The grief here is awful. It's similar to when an older loved one dies, and people can have PTSD from this. And we'll talk about this again at the end of the semester when we talk about death. So children can still do some things, even though they are relatively useless. In terms of sight, they can pay attention to the most important things, and this makes sense. Things that are moving, things that are different, things that are contrasting greatly with the background. They also can sense brightness, and they have the ability to distinguish colors. Now, your book says they tend to like blue and green objects. I've also seen red and black. I think it probably has more to do with contrast than it has to do with colors themselves, though. And how can we tell they like these things? It's through a process called habituation, but we'll talk about that later in the semester. In terms of sound, they've got a pretty decent sense of sound. They startle easily, but they also have a sense of familiarity. When newborns cry, when other newborns cry, a newborn will likely cry, and it seems maybe kind of evolutionarily as an alarm call. If there's something going wrong with one of them, it can be with others, or it could just be a way of getting even more attention for the child who's crying. Nonetheless, if they hear a recording of themselves cry, they oftentimes don't cry. It seems like many infants have a sense of what their voice is like, which is really weird. In terms of touch, they respond to touch, but we don't know as much here. We do know that sometimes they can react to puffs of air that are so weak, even adults don't notice them. So that's a kind of cool finding. And then last year, in terms of taste, they suck a lot. And there's a lot of weird studies that show things. Your book points out a couple of them, that they increase sucking when they smell peppermint. There's a lot of different things like that. If your child's having issues nursing, there's a lot of homeopathic remedies that people will try out like that. Okay, so let's talk about learning. They can learn actually relatively well fairly easily. Just like, so first of all, classical conditioning, as you guys remember from the learning and social learning theory lectures, this is the Pavlov's dog situation. So Watson conditioned little Albert, remember that? It seems that they can have this fairly early on, the ability to be classically conditioned. One study found that 1 to 2 day old infants who were stroked on their head before they were given a drop of liquid soon turned their heads to suck at the stroking alone. So they were conditioned for this stroking. In terms of operant conditioning, this again is where there's the voluntary response. Infants learn fairly quickly, and we could say that it's innate actually, that crying gets attention. So they do it a lot. And even beyond that, there have been some things that have shown that they will suck on a nipple if they hear their mother reading a story. And then if the mother stops reading, they can suck even more in an attempt to get her to do it more. So even if they're not feeding, which is cool. So habituation, I mentioned this in the last slide. This is where there's a decrease in a response to a stimulus after repeated presentations of that stimulus. It's a decrease in response to a stimulus after repeated presentations of that stimulus. Basically, when babies see something new, they stare at it for a long time. After a while, they'll stop. They know it. They have become habituated. Well, babies actually can stop sucking on a nipple when a new stimulus is shown. It seems like they drop everything to just stare. It's kind of like when people stop eating when there's an interesting story or something, as your book points out. This habituation is actually important. It's one of the first signs of the ability to learn. If there are difficulties in vocal habituation, it can be a sign of some kind of developmental delay. But this habituation is also one way we can tell how well children like different things. If they're looking at something for longer periods of time, we tend to think they find them more interesting or like them, even though it's not cognitive at this point, obviously. In terms of social learning, newborns back in the day, there's actually some controversy over whether or not they imitate one another. So they were found to imitate each other's behavior. Then in the 70s, it contradicted that. So you go and educate yourself on it. Some newer studies have found that there was sticking tongue out imitation, but it disappeared at 2 months. Educate yourself. There's too much to get into here. So now on to everybody's favorite part, a birthing video. Everybody seen one before? Well, we're actually not going to watch a birthing video, in part because I don't have access to one that I know isn't just somebody putting their own video up on YouTube, which is odd, but believe it or not, there are videos on YouTube of it. So check it out when you get a chance. It's, again, easy for me to say, but I would think you would want to see that before actually going through it. And it also serves, along with talk of episiotomies, birthing videos are actually probably the best form of birth control that I know of. And then lastly, this is somewhat unrelated, but not completely. The United States is one of the few countries in the world where there is no paid maternity leave. No other country in the world that is nearly as wealthy as we are has this situation. And the concerns that are brought up usually is about employers having issues with but there's actually been no evidence in other countries similar to the United States that these deleterious effects actually took place. So it seems like the concern over what would happen if we allowed paid maternity leave, nowhere else in the world has it been a problem like people say that it will be. But there's just seems to be no will to get it passed. And even in other countries where they are expanding paid maternity leave, it's actually helping in part because you are giving a mother and child less stress, families less stress, which is big, allowing them to do early education, more reading, etc., etc. And so it definitely seems like something that we should take up, but there just is not the political will there for it. All right. So we covered a lot in here. Please make sure to ask any questions you have. And if you are too afraid to put questions on the discussion board, just feel free to send me an email. Any question that you have that you think is dumb is nothing compared to questions I've got in the past. So please ask away.